Hello, my name is Greg Kinzer and welcome to another Spear Study Club module. The topic for discussion for this module is congenitally missing lateral incisors. And I'm sure like me in practice, you see a lot of young patients who are congenitally missing one or maybe both lateral incisors. So before we begin tonight, I would like to just have you have a little discussion amongst the group about young patients congenitally missing laterals. Knowing that most of these patients now are treated with implants, that is really the standard of care to replace these missing teeth. That's not my question. My question is, given the age of these patients, how do you replace the tooth in an interim basis? If it's a male and they have to go until they're in their 20s for an implant, how do you replace the missing tooth? Is it just a flipper, or do you do something maybe more definitive? So have some discussion on interim tooth replacement for these young patients before they get to the age where you can place an implant. Okay, let's begin, and we're going to talk about, again, missing lateral incisors, congenitally missing lateral incisors. The objectives that I would hope that you take from this module is to identify the different treatment options for replacement of missing laterals, because even though an implant would be our first choice, as we're going to see, there are patients where we can't place an implant. Maybe because they choose not to have an implant. They don't want to have the necessary surgery. Maybe they don't want to have the necessary orthodontics. So we have to have the ability to look at different options to replace that lateral incisor. And in the process, look at the indications and contraindications from some of these different treatment options. And then we're going to end with looking at a clinical technique of an option that, although we don't have to use it routinely, it's nice to have in our bag of tricks, and that's a pin ledge cantilevered restoration. So let me introduce you to Angela. Angela is 20 years old, and she's congenitally missing her laterals. Now, she's actually had some treatment before she came in to see me. She's had implants placed in both 7 and 10 when she was 18 years old. Unfortunately, neither implant integrated. So at the time of uncovery of the implants, they had to be removed. They augmented the ridge. They came back a year later and placed new implants in the areas of 7 and 10. This time, number 10 integrated and was subsequently restored, but number 7, after a month of having the restoration place, showed that it wasn't integrated, so it was again now removed. So what does she have? She has a temporary resin bonded bridge replacing her right lateral, and she has an implant restoration on her left lateral. The bonded bridge is loose. She wants to have something more definitive. She doesn't want to have to worry about it continually coming off. So her concern is, even though the implant was restored in 10, she doesn't like it. She doesn't like the aesthetics of the implant restoration. So she would like me to address that. But she wants to have a more definitive restoration in tooth number 7. She has 2 criteria. She does not want another implant. She is soiled on the idea of implant. She's had 2 implants that didn't integrate. Now, how often do you have patients that have implants that don't integrate? For us, it's actually relatively infrequent. I won't say it never happens, but it doesn't happen frequently. We've never had a patient where we've placed 2 implants and both implants have failed to integrate. So this was the first time I had seen something that failed to integrate in the same area. I discussed with her about placing another implant, but maybe we use a different surgeon. Maybe we use a different implant. Okay, let's change something up. But she says, nope, I won't have any of it. I don't want to have an implant. In fact, I don't want to have any additional surgery. So you can see the ridge is deficient. We talked about if we didn't do an implant, it would be nice to at least to augment soft tissue. She says, no, I don't want to have any additional surgery. So we have an edentulous site that we need to restore with something that is now tooth supported, and we now can think about replacing the implant restoration on the left lateral to improve the soft tissue aesthetics. I'm not going to discuss what needed to be done with the left lateral. So I'll just say that this is, to me, this is not a gingival augmentation needed. This is soft tissue management from a restorative side. Change the subgingival contours of the new restoration to impact the aesthetics of the soft tissue profile and the tooth shape. What we're going to do is we're going to spend time, though, talking about the different tooth-supported replacement options to replace her right lateral incisor. She's had ortho. You get the appearance now from these photos that the centrals look like they're proclined. Okay? So centrals, laterals look a little bit proclined, which is true if you look at her models. So she's got a class 3 tendency. It was treated orthodontically and it was corrected by proclination of the upper anteriors. So I want you to go ahead and pause the DVD at this point and talk about, if we can't do an implant, what different treatment options might we be able to suggest that are now going to be tooth supported? What criteria would we need to assume that if we chose this option, let's just say a resin bonded bridge, what do I want to do to make sure that resin bonded bridge is predictable long term? Then we'll come back and we'll talk about some of these different options, the indications and contraindications. So if we can't do an implant, that means to replace the missing tooth, I have to do something that's tooth supported. And I have some options. I could do something that is resin bonded. So a typical like a Maryland bridge or Rosette bridge. I'm just going to refer to them as a resin bonded fixed partial denture. I could do a cantilevered fixed partial denture. Okay, so instead of doing 2 retainers with the Pontic, I could do 1 retainer with the Pontic. That 1 retainer might be resin bonded. That 1 retainer might be resin bonded with some mechanical resistance and retention. Or I could do a conventional fixed partial denture. Now, conventional meaning I do crowns on the adjacent teeth. Maybe in my cantilever, I do a crown and cantilever. So there's a lot of different treatment options that I could provide to replace that missing lateral incisor. Let's start with the most conservative of the lot, which is something that is adhesively retained, a resin bonded bridge. Resin bonded bridges, if you look in the literature, can be very successful. Okay? But they also have the most stringent criteria associated with them to make them successful. Because I have to have the correct overbite, I have to have the correct incisor inclination, and I have to have mobility of the abutments be conducive for my resin bonded bridge. And I'm going to like to go through the overbite, inclination, and the mobility of the teeth. Because if we have a negative in either of these categories, the long-term success starts to go down dramatically. So if we think about overbite, how does overbite impact the predictability of a resin bonded bridge? The overbite directly impacts it because the deeper the overbite, the less palatal surface I have to retain the resin bonded wing. So the highest incidence of failure rate for resin bonded restorations are deep overbites. Contraindication for resin bonded bridges. Because I have a very small amount of area to bond to, or I have to prep into the tooth and have my lower anterior contacting on my abutment wing. The most predictable resin bonded bridge types of patients are minimal overbite, because I have less lateral forces on the teeth and I have a greater surface area to be able to bond my retainer. If we now look at our patient and we look at the amount of overbite, she has a very minimal overbite. So from a resin bonded standpoint, this could be a very predictable restoration with regards to overbite. The other area that we have to evaluate is not only the overbite, it's the inclination of the teeth. So in this example, teeth with a very proclined appearance, how does the force get transferred to that resin bonded interface? The more proclination the teeth have, the force between the tooth and the resin bond becomes more tensile in nature, compared to having teeth that are more upright. More upright teeth, the force now is more shear. If you think about loading something in shear versus tensile, the research in physics would tell you that you can load something with a shear force 30% greater before it fails compared to a tensile force. So tensile loads are not conducive to being able to get a good bond or maintain that bond. If we look at our patient and we think about the inclination of the teeth, what do we notice about the anteriors? They're significantly proclined, which now means that we're going to have more tensile force. Not conducive to doing a resin bonded bridge because that bond will break down because of the force. The last area we have to evaluate is the mobility of the abutment teeth. Now, mobility impacts us in two ways. There is directional mobility. All teeth are mobile buccolingual. The difficulty when you're restoring a lateral incisor is buccolingual of the central is in a different vector than buccolingual of the canine. So now imagine you have one abutment that moves this direction and the other abutment that moves this direction, and it's the goal of the resin bond to try to hold those teeth together. The other issue with mobility is differential mobility. If you have, the best resin bonded teeth would be teeth that are ankylosed because they're not going to move at all. No mobility, directional or differential. What hurts when you start to think about a resin bonded bridge is different mobilities. Let's say the central has a 1+ mobility and there's no mobility to the canine. Pretty typical. Canine's big, long roots, not a lot of mobility. You have a retainer now that's trying to hold these teeth to be unmobile. What we tend to find is when you have a failure rate with different mobilities of teeth, the tooth that basically fails is the one that's bonded to the least mobile tooth. So if we think about our patient, I told you that the current resin bonded bridge is loose. It's not out of her mouth though, is it? It's still bonded in her mouth. So which retainer do you think that it came loose from? Well, we have the central, which is going to put it into a shear force. The central has more mobility to the canine. So where does it come loose? It comes loose on the more strong abutment tooth. So in this case, it's debonded from the cuspid. So from a resin bonded bridge, trying to do a resin bonded bridge, probably very unpredictable. In fact, she's already shown us that it's unpredictable because the current restoration that she has as a provisional has it already adhesively debonded. So I'm not going to want to do a resin bonded conventional 2-unit fixed partial denture. I might, though, decide to do a cantilevered fixed partial denture. And my cantilever could be full coverage, partial coverage, or even resin bonded. Let me show you a different patient, another patient who is congenitally missing lateral incisors. If you look, she's had a resin bonded bridge, and her dental history is that it came off, and it repeatedly came off with a shorter interval before it became underbonded. They started to put holes in it to try to hold it in place. Finally, the joints fatigued and it broke. So she comes in to see me. She's 18 years old. She wants to have implants. Here is the radiograph. Given the position of the roots, there's no way we can do implant placement until we do some ortho. But what you need to understand, and what was interesting for me on this case is, I didn't understand the difference between root angulation and root inclination. Because root angulation is basically roots that are converging from a mesial-distal standpoint. Orthodontically uprighting the teeth gives us room for the implant between the apices of the roots. But there's a difference between root angulation and root inclination. Inclination is if you have teeth and a canine is proclined and the central is proclined, the proclination of those teeth as they turn the arch form converges the roots. So this is kind of what the appearance is with proclination of the teeth. Ideally now you would want to take the teeth and move them apart, move the roots apart. Unfortunately, that movement would necessitate taking the roots and moving them out of the alveolus. So we refer to this phenomenon with inclination as more of a wagon wheel effect, where we have enough room and the coronal aspect of the teeth are in the correct positions, but as we look at the intra-radicular position, the roots are converging. I learned this by sending this young patient to orthodontics for a year. And the orthodontist said, I can't get room between the roots. And they'd send me an x-ray. And so I would call them and I'd say, you're not trying hard enough. Keep doing the ortho. So finally, the orthodontist says, I can't do it. It was only then that I realized that it was an inclination issue. Without actually moving the roots facially out through the alveolus, we couldn't get room. So we ended up having to do a cantilevered restoration to replace a lateral. I chose to do a full coverage cantilever off the canine so I could change the facial aesthetics of the canine. If the teeth on the canines looked nice, if the facial aesthetics was nice, I would have done a palatal partial coverage. But here I can actually bring and change the relative appearance of the facial aspect. Augment the ridge with soft tissue, and here is now the cantilevered lateral incisors off the full coverage retainers on the canines. If you think about the success rate of cantilevering laterals, the success rate of cantilevering things is much higher on lateral incisors. This is a recent paper that was just published in 2014. Clinical survival of anterior, they looked at metal ceramic and all ceramic cantilevered restorations. Their success rate, this is a 60 months, so it's about 5 years. 40 resin bonded bridges, metal ceramic resin bonded on half, all ceramic resin bonded on half. Their success rates, 100% with the metal ceramic, 90% with the all ceramic. Where did the failure rate come in the all ceramics? It was either debonding of that all ceramic or fracture in the joint. Okay? So nowadays we have the ability to do all ceramic cantilevered restorations and even do them adhesively retained as long as we can get a good bond to the intaglio surface. Why do the cantilevers work so well? Why does a cantilevered resin bonded bridge work so well compared to using two abutments? Because most of the problems with a resin bonded bridge have to do with teeth that are moving in different directions. When you have only one abutment, the pontic moves with that one abutment. So there is no difference in the mobility and direction of the mobility. It moves with the tooth. The reason a lateral is so predictable a cantilever is we can protect it functionally. I can have a centric contact on it, but as soon as the tooth or the patient moves protrusively or laterally, I can free the lateral up from any excursive contact. So really predictable restorations, cantilevering off teeth or even cantilevering off implants. So I could do for her, I could do a cantilevered fixed partial denture. Maybe I would do it adhesively retained. Maybe I could do it by doing some preparation on the palate. There are patients, though, that we might choose to replace that missing tooth with a conventional fixed partial denture, a full coverage bridge on the central and the canine. What's the consideration of doing it? Well, first thing would be is if I needed to restore the teeth with full coverage because of breakdown or caries or old crowns, I would probably be thinking about doing something maybe that's full coverage. But from an alignment standpoint, the other thing that I would consider is look at the alignment between the canine and the central. In fact, if I'm looking at it from a frontal perspective, I'm going to look at the facial aspect of the canine relative to the alignment of the central. If they're relatively well aligned, I can do a much more conservative or normal preparation on both teeth. If the canine were to be proclined so that facial surface isn't in line with the long axis, you can imagine to prepare these teeth to get them to draw, I'm going to have to take a lot more tooth structure away. I'm going to have to be way more aggressive. So I'm going to look at it from an alignment standpoint frontally. I'm also going to look at it from an alignment standpoint laterally. So looking at Angela, the facial aspect of the canine and the central look to be in a pretty normal plane of space. So I could do a full coverage. I'm not saying that I would want to, but that's how I would evaluate the patient. From a lateral perspective, I'm going to look at the facial aspect of the central relative to the long axis of the canine. I can keep much more normal alignment when I have those two teeth parallel. If I have proclination of the central, now imagine to get those two teeth to draw, I'm going to have to prep a lot more aggressively either on the facial of the central or on the distal of the cuspid. If we look at Angela, there's some proclination appearance to the canine as well as the central, so I could get them to draw, but the path of insertion would be more of a path that's angular following the path of insertion of the central. What would be our treatment option if we can't do an implant? If she's saying, I don't want to do an implant, do we do something with 2 retainers, adhesively retained, 1 retainer that's adhesively or cantilevered? Go ahead and now have a discussion. Now that we've looked at things a little bit more intricately, how do you want to restore her? Because her goal is no surgery, and whatever you do, I want it to be predictable. I don't want to have to worry about it coming off 5 years, 10 years, and having to redo everything. So, welcome back. Hopefully you had some discussion on different options, and hopefully you're thinking doing something that is minimally invasive. I will tell you that when I restored this case, we're now looking at about 1999, 2000. That's when this restoration was placed. My thinking nowadays would be completely different. What I chose to do was a partial coverage cantilevered retainer, and I'm going to use the canine to cantilever the lateral. What I'm going to choose to do is I'm going to choose to do it as a pin ledge to try to get some mechanical resistance and retention as well as bonding. Looking at the current research that's out, I would actually now be thinking of doing it as a resin bonded restoration. You can have some discussion on how you would design it. Would you design it to be zirconia, which has a lot of strength in that connector, but a more unpredictable bond to the intaglial surface of the retainer on the canine? Or do we use maybe Emax? Emax has a good bond, but it's a weaker material. So do we go for bond? Do we go for strength of the connector? And that's kind of the payoff between the two. There are times when we actually do a little combination, is I'll do a zirconia insert that now has Emax pressed to it. So I have strength in the connector. I can keep the connector smaller, but I have on the intaglial surface, I'm not bonding to the zirconia, I'm bonding to Emax, so I get a better bond of the tooth. Technically, it's a little more challenging for the technician, but I can kind of get the best of both worlds. But what we're choosing to do, given the time period that we didn't have zirconia back when this case was restored, didn't have lithium disilicate in the norm that we see it now, I want to do something that actually has predictability long term. So I'm going to choose to do a pin ledge palatal partial coverage retainer on the canine. This is a pin kit from Whale Dent. Unfortunately, they no longer make this because there wasn't a lot of these probably being used. Doesn't mean we can't do it now. What the pin kit had in it, it had a twist drill and it had 3 different pins. It had a plastic impression pin, it had a aluminum pin for provisionalization, and then it had a palladium pin that you would be able to put in and cast to. They don't make this pin kit. They still make, though, they make the twist drill. And if you have the twist drill or buy the twist drill, that's really all you need because we can make up the other components. We can figure out a way to make some impression pins to stick in the holes. Okay? We can use small posts. We can use small plastic inserts to be able to get these things and cast them directly. So this is actually the most important part. This is what you need. It's not a TMS pin kit. Okay? It's longer. It's probably about 4 millimeters in length. And we're going to drop some pins into the palatal aspect. Now, before you drop pins in, you want to make sure that you know where the nerve is. What you don't want is you don't want to drop your pinhole in and then all of a sudden see a nice little red bubble out of the hole. You don't want to pump them into the end of the canal. So we're using the canine because it's a thicker tooth. On this patient, I'm going to use a metal retainer. So the metal can, if we have a very thin tooth, and we have a very translucent tooth, a metal retainer can detract from the facial aesthetics because we can change the way light goes through. So canine's a thicker tooth. I just want to make sure I know where the nerve is. I'm going to drop 2 pins in. I'm going to drop one on the distal and one on the cingulum area. Now, they make fancy little clutches that you can put the handpiece in that act like a drill press. If you're doing 6 or 8 of these and you have to get them all to draw, I could see where that could be beneficial. But I think that we can get 2 pinholes to draw perfectly just with our own hands. It's hard to see from the clinical preparation where the extent is. I'm going to show you the model in 1 second. The most important part, aside from not hitting the nerve, is where do you carry the facial mesial extension of your prep? Okay, this is crucial. If you carry that facial extension too far facially, you will now show metal interproximally. So how do you decide how far to prep? I would wax the case up, and I would look to see where the lateral and the mesial of the canine contact each other. That's going to influence how far facially I can carry that junction. Okay? Crucial. You can create an anesthetic restoration by carrying it too far facial. So this is the plastic impression pins. You could actually fabricate these yourself, just melt some plastic, make a little nail head retention. They go in the pinholes, and then it's a conventional impression that you pull out, and these stay in the impression. So here's actually the prep on the model. I have a groove on the mesial. I have a pinhole on the distal and a pinhole on the direct palatal. All of these draw. Since this is going to be gold, the rest of the reduction can be 0.5 millimeter. It doesn't have to be very deep. On the model, the technician now can make the palatal retainer. In this case, what I wanted my technician to do was make the palatal retainer out of gold, yellow gold. But he doesn't use a yellow gold for the metal ceramic restoration. So he's going to use his conventional metal ceramic metal. And then he's going to come back and we're going to post solder those 2 pieces together. Okay? Why don't I want the silver colored metal on the canine? Gold is a warmer color. I'm going to detract from the light, but the warmth of the gold won't have it be impacted as negatively from an aesthetic standpoint. Okay? Now, before you have the technician solder these 2 together, again, it's a post solder, you're doing it after the ceramics are done, because once you post solder, the heat taken for the solder is well below that of the ceramic. If you post soldered it and you tried it in and go, oh, I wish I would have stained it. I wish I would have added more color. I wish I would have added more incisal length. You can't throw it back in the oven because you'll melt the solder. So at this point, what you would do is I would take a little bit of resin and I would lute those 2 pieces together and I would try it in the mouth. Try it in the mouth in a bisque bake, evaluate the aesthetics to make sure that I don't have to take it back to the oven again. Then they're post soldered, and here now is my cantilevered restoration. And again, I said earlier that the most crucial part with these partial coverage, especially if you're using metal, is where do you stop the facial line angle or the mesial facial line angle of that retainer. Carry it past the contact, and all of a sudden you start to see little bits of metal in between the teeth. It starts to be a negative appearance. When you go to try this in, inevitably there's going to be a little debris that presents itself into the pinholes. So you take your twist drill, clean your pinholes out again, and try everything on. Air abrade and bond this in with resin cement. Real, predictable, long term. You could do this nowadays. You could actually pick the pins up by using Emax or even using, couldn't really use zirconia, but you could do Emax, wax and press the Emax to it. So here's where the patient finished. Just a new implant restoration on the left lateral. Only thing that was done there was change the subgingival contours to provide a better emergence, to move the tissue apically so I get symmetry of the gingival margins of the implant and the cantilevered restoration. Even though implants are our primary treatment planning decision, there are times where patients don't want implants. They don't want to do the necessary surgery, they don't want to do the ortho, so we have to rely on something that would be done tooth supported. I would start to think more conservative and then figure out why I couldn't do the one that's more conservative. What are the contraindications for doing something that's resin bonded? But I would also be thinking cantilever. Cantilever either off the canine or the central can be a very predictable restoration, especially in a very conservative fashion. So hopefully this gave you some ability to think maybe a little bit outside the box on how we can replace missing lateral incisors in a tooth-supported approach as opposed to an implant. Thanks very much. We'll see you again.